So our next speaker is Dr. Olivia Smibert. Olivia will be presenting today on updates to the febrile neutropenia content in the Antibiotic Guidelines. Olivia is the lead for transplant infectious diseases at Austin Health and a PhD candidate at the Peter Mac Cancer Centre and the University of Melbourne, having completed a transplant infectious diseases fellowship at Massachusetts General Hospital in 2019. She is the recipient of multiple awards, including the 2019 NHMRC Gustav Nossel Postgraduate Scholarship Award. Her PhD research examines the role of the microbiome in infectious and immunological outcomes in immunocompromised patients, with implications for novel diagnostics and therapeutics. Please join me in welcoming Olivia to the stage.
Thank you very much. I'm really grateful for the opportunity to present and share updates to the febrile neutropenia section on behalf of my colleagues. I don't have anything to declare. No one wants to give me any money to do anything, but I just want to say I'm open to that if anyone has any offers. And I have to apologise, I'm suffering through my first 6 weeks of putting my first kid in childcare, and I am down with something like sandpaper in my throat and coughing, so I'm very apologetic that I'm sipping water, and hopefully I'll be able to get through this talk. Again, if anyone has any tips on how to survive this time, wowee, I'm feeling immune compromised at this point, so please share them with me. So the context to which this update was undertaken, rather like the CMV update, as Tina mentioned, was everyone will be aware that the consensus guidelines for the management of neutropenic fever were published at the end of last year. This was work led by Abby Douglas, Kaz Dursky and the NCIC group. And we were really fortunate that this update in the TG guidelines occurred while this was occurring simultaneously, and it was thought to be really important that we were aligned across both guidelines, and the consensus document really largely informed the direction that we took with the TG update. There are limitations in the scope as the TG recommendations are designed, and really they're for access at the point of care, really probably in settings where there aren't local guidelines for the management of neutropenic fever. And for this reason, there is a few points where there is comment to the dreaded seek expert opinion or local advice. And that probably reflects that there is some variation in epidemiology of resistance in some of the organisms that patients face, and we really should be encouraging people to, commence empiric therapy, but then seek local guidance for infectious diseases, microbiology, or the cancer centre from whence a patient may have come. The restructure of recommendations have changed slightly, again in line with the consensus guideline updates, and really reflect antibiotic recommendations that are to do with patients' clinical acuity and their risk of being colonised or infected with multi-drug resistant gram-negatives. So we've picked about 5 changes that we think are probably the most significant and worth highlighting to the group. And so just to summarise those briefly, the first is there's now a more tiered and nuanced approach in the recommendation for the timing to antibiotic administration in febrile neutropenia, and I'll go through why that is in a moment. Ceftazidime has largely been removed as a first-line antibiotic for the treatment of febrile neutropenia, so we really are looking at piptazo and cefepime as having equal weight, and that includes metronidazole that may be added to cefepime in the setting of an intra-abdominal infection or concern for perianal infection. Regimens with gram-negative resistant activity really are reserved for those patients with risk factors for gram-negative infection, as well as those who clinically meet a criteria of sepsis, septic shock, or require ICU support. And there's been a step back on how front and centre carbapenems and meropenems are specifically in the febrile neutropenia guidelines, and they've really taken a second step to aminoglycosides, which are front and centre as our sort of second gram-negative agent. Meropenems now are reserved really for those in whom an aminoglycoside might be contraindicated, or there are concerns for resistance to aminoglycosides, and in patients who have sepsis and septic shock and require ICU care. And finally, there's been a tweak to the times at which we would recommend vancomycin for resistant gram-positive infections, where they were traditionally recommended for patients with sepsis. They're now really, regardless of sepsis phenotype, recommended for patients in whom there's a clinical concern for a resistant gram-positive infection. So starting out with a tiered approach to the timing of antibiotic administration, we really previously had quite a prescriptive and time-based recommendation. For all patients with suspected or confirmed febrile neutropenia, start antibiotics within an hour, and we even went one step further in those who had concerns for sepsis or septicemia, which was within 30 minutes. The update in our new guidance in version 17 really breaks patients up into clinical acuity and suspicion. In those patients with confirmed neutropenic fever, we're sticking with an hour. And in keeping with sepsis recommendations, those who have sepsis or septic shock, we're also recommended an hour. So that's a relaxation of that sort of hardline 30-minute recommendation. And a third tier, again, is in those patients in whom there is clinical suspicion of febrile neutropenia, but who are clinically well. There's probably little evidence to sort of mandate a strict time to initiation in these patients. And because we're now thinking about some of the adverse effects of antibiotics, their impact on the microbiome, the development of resistance, we've made a suggestion that clinicians may take the time to undertake a clinical assessment, as well as waiting the results of an FBE if a patient remains clinically well before rushing to administer antibiotics. And similarly, we had also had a recommendation for 2 sets of blood cultures to be collected, immediately before administration of antibiotics. That remains, but with a caveat that if a patient is clinically unstable, you really shouldn't delay the initiation of antibiotics in order to collect these blood cultures. The rationale for this is twofold. Obviously, we're not here to debate time to initiation of antibiotics in septicemia, so in those patients who are clinically unwell, it's the golden 60-minute rule. But the evidence for time to administration of febrile neutropenia is actually quite poor. They're really limited to single-centre observational cohort studies with quite a lot of bias. And if you think about it, the time to initiation is typically measured from presentation to triage and is a continuous variable to, needle in arm with an antibiotic being administered. And if you've got a patient who presents, systemically unwell with sepsis, a sepsis syndrome or needing ICU support, that patient will be triaged more quickly and administered antibiotics, as opposed to a relatively well febrile neutropenic patient who there may be delays. So it's really hard to come up with a firm time recommendation for these patients. Because there are multiple changes across the empiric drug recommendations, we've now got a table which will hopefully make it easier for clinicians to navigate to the antibiotic recommendation that is relevant for the patient they have in front of them. And again, these reflect on the left-hand side the clinical acuity of patients, and on the right-hand side the likelihood that a patient is either colonised or has recently been infected with a multi-drug resistant gram-negative. And so some of the summaries compared with the previous recommendations on the right-hand side with the update. For those patients who have febrile neutropenia but who are clinically stable and do not have a risk of a multi-drug resistant gram-negative, I've mentioned that ceftazidime has been removed, and our frontline, given equal weighting, is pip/tazo and cefepime plus or minus metronidazole. And this has really developed, I would say, if you go back and look through the literature, actually probably over the last 10 to 15 years, concerns about the efficacy of ceftazidime in this setting. And there's actually been a really amazing network meta-analysis of about 50 randomised controlled trials comparing various beta-lactamase inhibitors and anti-pseudomonal beta-lactams across febrile neutropenia studies. And ceftazidime is not actually associated in this setting with increased mortality, but really with lower treatment success rate. Compared to other pseudomonal beta-lactams, and that includes in adults and children as a monotherapy, and in those with pseudomonal bacteremia, which has really led to most guidelines de-emphasising ceftazidime as a preferred first-line agent. For those patients who have febrile neutropenia and have risk factors for multi-drug resistant gram-negatives but who are clinically stable, previously this was where meropenem had quite a prominent recommendation in the guideline. And for the reasons that I mentioned earlier, we've sort of walked that back. And so there's no change to those patients who are just treated with febrile neutropenia without risk factors. And the reason for this is not necessarily because there's good evidence that a carbapenem is not useful in this setting. It's really sort of extrapolating from the data that there is no evidence that an additional gram-negative with an aminoglycoside in that context, so expanding gram-negative coverage, is associated with improved outcomes for patients. And again, there's great meta-analyses of data with thousands of patients with febrile neutropenia episodes to support this. And really the evidence of benefit in this setting outweighed the risk of harms is a primary consideration. In those patients who have febrile neutropenia and a septic shock but without risk factors for gram-negatives, Again, we had previously recommended aminoglycosides in all instances for these patients, and we've nuanced this slightly between sepsis and septic shock and sort of softened the recommendations for aminoglycosides and consistent with the consensus guidelines. And really, this is an evidence-free zone. This is probably highlighted as the evidence gap we need to fill in this guideline, that there are no randomised controlled trial data in this setting. We're really limited to observational studies that are variably in favour of combination therapy. However, a lot of the data that we use to inform our guidelines are from centres and places that are vastly different to the area in which we practice. So we have, thankfully, relatively low rates of resistance in our gram-negative organisms, and we don't practice in a fluoroquinolone prophylaxis setting. And a lot of these studies from Spain, France and the USA have really high rates of multi-drug resistant gram-negatives, including carbapenem resistance. So we have to, I guess, provide some pragmatism to the area in which we're practicing. Furthermore, a lot of this data was undertaken in a time where we didn't necessarily have such comprehensive bundles of sepsis care to offer patients. And we know that if patients can get to ICU and be appropriately supported, antibiotics become an important part of how we're treating them, but part of the therapy that saves their lives. So that's the approach that we've taken here in Australia. For those patients excuse me, with febrile neutropenia, sepsis or septic shock, and with multi-drug resistant gram-negative risk factors, we've previously recommended aminoglycosides or meropenem, and again, we sort of take a similar approach actually in this update. That's largely unchanged and really is probably best to be guided by colonisation status of the patient, known epidemiology, and this is where we sort of make a more firm recommendation that seeking expert guidance and local opinion is worthwhile, and leave the opportunity for a clinician who may be unclear or not have that resource available to them at the time, that they can just make a sensible choice, which we know in most instances in an emergency department, for example, may be to reach for a carbapenem. You know, so many of us, myself included, sometimes just feel better with a carbapenem. In patients who are systemically compromised with risk factors for multi-drug resistant gram-negatives, we've made the recommendation to be guided by local epidemiology, and we link out to the Therapeutic Guidelines section that provides a table listing the risk factors for colonisation with multi-drug resistant gram-negatives, and obviously there's a big emphasis on those who've recently travelled overseas, which wasn't previously as part of the document. And then finally, for those patients in whom there is a concern for a multi-drug resistant gram-positive infection, we recommend vancomycin be administered. And in the previous iteration of the guideline, resistant gram-positive coverage with vanc was recommended more or less empirically for those patients who were systemically compromised. And so that's a slight change actually quite a significant change in when we recommend gram-positives. And this is really informed by, again, quite a large body of evidence that suggests that patients don't really die with febrile neutropenia with gram-positive organisms, and that administration of vancomycin can be associated with significant toxicity, particularly nephrotoxicity, and contribute to increasing resistance, particularly in the enterococci in the gut. And so that's led us to sort of walk back that recommendation and recommend it only in those in whom there's clinical suspicion for infection. And as well, there's also a table where we sort of highlight exactly those patients in whom we're recommending or who may be at risk for a multi-drug resistant gram-positive infection. So in summary, this update was really undertaken in the context of the consensus guideline document for the management of neutropenic fever, and if you haven't read it yet, I'd encourage you to have a look at all the documents that are part of this update. They're an amazing body of work. They're designed and limited in their scope, in that they're for the patient or the clinician who's at the point of care, who may not have local guidance available or expertise, and that probably the biggest overarching structure is this division now into very clear sections based on clinical acuity and risk factor for multi-drug resistant gram-negative organisms. So thank you.
We've got time for one question. Does anyone have a question for Liv about febrile neutropenia?
I'm just curious about your definition of requiring ICU support. Would that also include patients that would be for that medically require ICU support, but they're not for escalation of care?
That's a great question. We don't actually specify that. I think it's a pretty liberal term, I guess, the need for ICU support. Not to be confused with patients who meet sepsis and septic shock requirement. I think that's where the clinical nuance comes in, and in most instances, if there's a patient with febrile neutropenia who's maybe at ceiling of care, they're probably already an inpatient and in a setting where there is local expertise defining those limits of care. But you're right, that's probably an important gap, that there may be confusion for a patient who, say, presents floridly unwell in a rural setting where there's no heme or ID support. That's not addressed clearly there.